I'm Dr. Tara Berman, and today I'll be talking about integrative gynecologic oncology, and my presentation is Hungry for Data, the connection between diet, cancer, and selective topics in integrative gynecologic oncology. So thank you all for attending. These are my financial disclosures. And today I'd like to start with a case report. So this is a patient that I often see in my clinic, Mrs. A 45-year-old woman with a BMI of 35, status post or have after she had surgery for total hysterectomy and bilateral salpingo-oophorectomy for stage 3 ovarian cancer. And she presents to discuss chemotherapy options with me, but she mentions that she is not eating well due to stress. She would like dietary recommendations and wants to know if she should eliminate all sugar since sugar feeds cancer. She wants to be prescribed a strict diet she can follow. And she has friends recommending supplements like turmeric, omega-3, green tea, probiotics, ivermectin, and fenbid. And this has actually happened. And basically wants to decrease her risk of overall recurrence. So Mrs. A's concerns are going to inform the flow of today's talk. Well, I'll be addressing physical activity and lifestyle modifications, supplements, therapeutic and harmful effects, eliminating sugar and transitioning into the ketogenic diet, fasting, and talking about probiotics and the microbiome. A little bit about me and my connection to integrative oncology. I'm a medical oncologist specializing in gynecologic oncology and integrative oncology. I have a master's of science in nutrition from Columbia University. I serve on the board of the Society for Integrative Oncology. I have regulatory experience at the FDA working as the integrative oncology liaison for the Center for Disease Evaluation and Research. And currently, I'm working at the Dana-Farber Cancer Institute as a medical gynecologic oncologist and the co-director for the SETI Clinic, the Center for Early Detection and Interception in Gynecologic Malignancies. And we work closely with the Zagam Integrative Oncology Center. So let's start today with what integrative oncology is. Integrative oncology is defined as a patient-centered, evidence-informed field of cancer that utilizes natural products, lifestyle modifications, example, diet, and mind-body practices alongside conventional cancer treatments. It's not just natural products without treating cancer with chemotherapy, for example. It's a culmination of all of these things together. And the medicinal use of plants is nothing new. We have been using plants for medicine for the last 60,000 years. And today, 80% of the world still uses plant and plant-based products to treat medical conditions. So moving on to lifestyle modification. Did you know that over 50% of cancers are preventable? Excess body weight, poor nutrition, physical inactivity, and excess alcohol consumption is responsible or associated with causing about 1 in 5 types of cancer. And being overweight or obese raises a person's risk of getting one or more of 13 types of cancers. And among the US, the preventable risk factors include smoking. Tobacco use is responsible for about 33% of cancers, 20% of cancers due to obesity or being overweight. The microbiome can cause about 16% of cancers with cancer-causing pathogens. We know that exercise can reduce risk, and 5% of cancers are due to either poor dietary habits or insufficient physical activity. And the sun is responsible for about 2% of cancers, including skin cancer. Oh, sorry, moving the wrong way. Do you know which cancer is most strongly associated with obesity? And feel free to write this in the chat if you want to take a guess, but I'll move on in the interest of time. And the answer is endometrial cancer. Among women, obesity is more strongly associated with endometrial cancer than any other cancer type. 57% of endometrial cancers in the US are attributable to being overweight or obese. And for every 5 units of BMI increase, that's body mass index, there's a 50% increased risk of developing endometrial cancer. And why is this? We know that there's an elevated estrogen concentration in adipocytes or fat cells. When patients are overweight or obese, there's a state of hyperglycemia and there's hyperinsulinemia. And this leads to chronic inflammation, immunosuppression, increased production of inflammatory cytokines, and microbiome changes in the gut and uterus. And the Cancer Genome Atlas has identified almost 200 genes that are either upregulated or downregulated significantly with a change with increasing BMI. So having an increased body mass index can change how the genes are upregulated or downregulated in our body. And obesity is also associated with risks of other cancers. If you want to take a guess and put some of them in the chat, um, I'll give you a minute to do so. But moving forward, being overweight or obese can increase also your risk of ovarian cancer, colorectal cancer, postmenopausal breast cancer, esophageal cancer, pancreatic cancer, and kidney cancer, just to name a few. Now, why is this? Again, this is a more of a schematic of some of the hormonal changes and changes that occur in the body in obesity. We know that the adipocytes, the fat cells themselves, can produce hormones like estrogen, inflammatory cytokines, even influence cancer stem cells and fibrosis. Now, what about BMI and ovarian cancer? We're here to talk about ovarian cancer today. What do we know so far? We've already shown that adipocytes and adipose tissue, basically fat, promotes the proliferation of ovarian cancer cells in vivo and in vitro. And in most clinical studies, the impact of having a high body mass index on the prognosis of ovarian cancer has been controversial. So I wanted to highlight this study that was published pretty recently in July 2022 that showed that obesity negatively affected prognosis of women with ovarian cancer in this analysis. And they focused on women that had a history of peritoneal dissemination, so dissemination in the pelvic cavity, abdominal pelvic cavity, and who have had complete resection in the primary surgery. So in addition to greater surgical difficulties, gynecologic oncologists like me need to consider the potential risk of stealth peritoneal metastasis when treating patients with obesity, especially after a complete resection has been performed. So what this study really shows is that there was an increased recurrence of disease with patients with a higher BMI and a decreased overall survival, which is really important. Why do we think this is? Again, focusing on the fat cells and the crosstalk with cancer cells. The cancer-associated adipocytes can stimulate lipolysis or breakdown of fat and functional adipocyte changes, and the fat can provide fuel for the cancer cells to grow. So it's this feedback loop that occurs, and we can stop this by controlling body weight. We also know that ovarian cancers have a predilection for metastasizing to areas of fat in the body, including the omentum, which is the fatty apron that covers the abdominal pelvic organs. In this first figure here, this is a healthy omentum, and you can see it's made mostly of adipocytes here, or fat cells. And then this patient with cancer, you could see that the omentum had tumor. It was covered in tumor, and the ovarian cancer metastasized right to the omentum. And you can see that normal cells in the cell study on the bottom really don't invade fat cells normally. But when you look at the ovarian cancer cell lines and the number of invaded fat cells, you can see a positive change, a very high increase. And we see this in other cancers as well, but ovarian cancer has the highest predilection for spreading to fat. So what can we do about this? Knowing this, what does the American Cancer Society say for guidelines for reduced cancer risk? They're pretty bare bones. The ACS just recommends maintaining a healthy body weight or a normal BMI, regularly exercising 150 to 300 minutes a week of moderate intensity, or 75 to 150 minutes of vigorous activity, or combining the two throughout the week, limiting sedentary behavior, limiting alcohol, and following what they call a healthy eating pattern, which is pretty intuitive. Eat more fruits and vegetables and less junk. The 2018 WCRF and AICR score includes the World Cancer Research Fund and the American Institute for Cancer Research combined forces and added a scoring system of 10 cancer prevention recommendations, which are pretty similar to the ACS recommendations, including be healthy, have a healthy body weight, be active, eat diet that's rich in whole grains, vegetables, fruits, and beans, limit fast foods, foods high in fat, sugars, or starches, limit red meats and processed meats, limit sugar, limit alcohol, not to use supplements for cancer prevention, and we'll talk about that data. Mothers can breastfeed babies, and follow up. The last recommendation is to follow the other recommendations. And this particular group studied patients who adhered to their recommendations and found that those who adhered to their recommendations were associated with a lower risk of three particular cancers, including breast, colorectal, and lung cancer, but there was no significant associations with following these recommendations and reducing risk of prostate cancer or other cancers, which means future studies investigating associations with other risk of other forms of cancers like ovarian cancer are warranted. Bringing us forward to diet and fasting now. Just doing a quick precursory search on PubMed has revealed multiple clinical trials in process now that are enrolling, that are looking at dietary and exercise interventions in cancer treatment and prevention, which is an exciting time. We have discussed in our practice and at Dana-Farber this FAITH study that includes an insulin suppressing diet with one or two drugs called cerebellasib and Abraxane to treat endometrial cancer. And this is just to show that we're really taking dietary interventions seriously in the oncology world. We're incorporating them into our randomized controlled clinical trials, which is really exciting and I think impactful as well. Of note, there are no approved metabolic therapies at this time to treat malignancies or a diet that's recommended as a possible adjuvant to treatment today. I think this will change, but officially we don't recommend anything on paper for now. There are, unless in the under the auspices of a clinical trial. We can use diet or fasting, however, to target certain hallmarks of cancer, including cancer's altered cellular metabolism and energetics, making a person's body pro or anti-inflammatory, and taking advantage of cancer genome instability and mutation status. This was an effort that I collaborated on with my colleagues from the Society for Integrative Oncology, looking at integrative medicine for ovarian cancer. And what we found through our meta-analysis, or just analyzing different studies, was a positive association between a high glycemic index, so high sugar index, and risk for ovarian cancer, with an inverse association with high fiber intake. So high fiber was protective against developing ovarian cancer, and having a high glycemic index was associated with a higher risk for ovarian cancer. We identified studies that found a potential increased risk for ovarian cancer with a pro-inflammatory diet. That includes a diet high in saturated and trans fats and whole milk consumption, particularly with high intake of lactose, total sugars, and high glycemic load. And this was especially true among African American women. And in Australia, a study revealed increased rates of survival with higher levels of vitamin D at the time of diagnosis. So vitamin D may be protective against developing ovarian cancer. Now, what about the ketogenic diet? We know that cancer loves sugar, and we actually exploit this predilection for cancer, or this love of cancer, in our PET scans. We give patients a special type of glucose called FDG, fluoridated. It's a radioactive iodine attached to a glucose molecule that we use to detect cancer in the body, because the cancer cells are consuming the higher glucose or the higher radioactive glucose, and they light up. These areas light up on scans and help us with cancer detection. We know that cancer cells metabolize 200 times more glucose than our healthy cells. So we can target cancer metabolisms in diagnostics, but what about in treatment? And this question comes up in clinic a lot with me. We know that cancer, there's many different types of sugar. The simplest form is glucose. So when I say glucose, I'm talking about a simple form of blood sugar. And we know that healthy cells and cancer cells use glucose as a main energy source. When taken away in a healthy person, the body will use proteins and fat for fuel. And they break them down into amino acids and ketone bodies. And this is the premise of the ketogenic diet and fasting. And then in the early 1900s, over 100 years ago, Dr. Warburg discovered that tumor cells have an aberrant or different metabolic pathway, and that cancer cells rely on aerobic glycolysis. They don't have time to break down glucose the way that our healthy cells do, and they need a very, very, very quick turnover. And when that glucose source is taken away, the cancer cells have a lot of oxidative stress, and it puts them, they can't survive as well as our healthy cells can. So this promotes an energy deficient state when we take away glucose, leading to lipolysis, breakdown of fats and proteins, and eventually cachexia. It's also a great way to lose weight. So the ketogenic diet basically kind of mimics fasting in a way, because it increases reliance on fatty acids instead of glucose, And a low serum glucose triggers hormonal changes like the breakdown of fat. And again, there's an accumulation of amino acids and ketone bodies in the liver. And healthy cells can be okay using these for fuel sources, but this puts a lot more metabolic stress on cancer cells. So perhaps a ketogenic diet combined with cancer therapy might increase efficacy. And these are questions, and this is something that we're looking at now with clinical trials. In the University of Alabama, our gyn-onc colleagues found favorable effects of a ketogenic diet on overall quality of life. Is this a feasible diet for women with cancer to try to adhere to? And the answer was it was well tolerated. It actually improved physical function, perceived energy, and food cravings in women with ovarian or endometrial cancer on a randomized controlled trial to prove that, again, ketogenic diet does not diminish quality of life. A ketogenic diet, as we know, is well tolerated in terms of short-term side effects and long-term side effects. You can see hypoglycemia, decrease of blood sugar, dehydration, lethargy, rarely ketoacidosis, and constipation or diarrhea. Long-term adverse effects include hyperlipidemia, high cholesterol levels, kidney stones. It's not a good idea for children. They can have bone mineral loss. Rarely acute pancreatitis or cardiomyopathy can develop, or acute hemolytic anemia. But basically, we found that through multiple studies, there's evidence for beneficial effects of ketogenic diets during cancer therapy. But again, more high quality studies are needed to assess the overall strength of evidence. So before everyone goes and starts thinking about starting a ketogenic diet, this study in a mouse model by my colleague, Dr. Miriam Al-Hilli in Cleveland Clinic, actually found something surprising. Her mice who are predisposed to develop ovarian cancer, her ovarian cancer mouse model essentially had accelerated tumor growth and an increased tumor burden for the mice that followed the ketogenic diet. So this is conflicting evidence to what we know and think about a ketogenic diet and what it does. And one of the reasons could be that we know that ovarian cancer cells have a predilection for fat. So maybe a high fat diet, which is what is followed in a ketogenic diet, might not be optimal. So again, there's conflicting data out there, so nothing ready for prime time yet. As far as diet goes, what about intermittent fasting? Intermittent fasting has been deemed the most popular dietary intervention in patients with cancer as of recent years. And there's different ways to follow to pursue intermittent fasting. You can either do time restricted feeding, where patients can eat only during either a 6 to 10 hour window, 5 to 7 days a week, or there can be 5 to 2 intermittent fasting, where there's 1 or 2 days a week, but very, very low caloric intake. So there's different permutations and ways to follow intermittent fasting. What does the data show? So I like to refer to this study. This was a case series with 10 different patients receiving chemotherapy who pursued different modalities of intermittent fasting. And overall, fasting was found to be safe and well tolerated and reduced fatigue, weakness, and gastrointestinal events reported while fasting. And various cancers were looked at. Of course, because we are talking about gynecological malignancies, I'm going to focus on the 2 gynecologic cases that were shared in this case report. And the first case was a stage 4 uterine papillary serous carcinoma, or endometrial cancer. This patient was receiving carboplatin and paclitaxel, 2 very commonly used chemotherapy drugs in the GYN setting. And cycle 1 was an ad lib diet. So the patient could have eaten whatever she wanted. And you can see here for cycle 1, she already had grade 2 fatigue, weakness, hair loss, headaches, nausea, vomiting, diarrhea, and other symptoms. And when this patient adhered to fasting for cycles 2 through 6, and this is an intense fast, this is a 36-hour fast pre-chemo and a 24-hour fast post-chemo with adequate hydration and fluid intake. But you can see here reported reduction in the severity of chemo-associated side effects in this particular case. So fasting was protective against adverse effects. And then in this patient with recurrent ovarian cancer with carcinosarcoma receiving gemcitabine and docetaxel, fasting led to faster recovery of blood counts. And this patient did a 62-hour pre-fast and 24-hour post-chemotherapy fast. And she was having a lot of myelosuppression and suppressed counts, including neutropenia, lymphocytopenia, and thrombocytopenia. And fasting actually improved her blood counts and made the chemotherapy less toxic. Again, these are just two cases presented here showing that fasting in combination with chemotherapy is feasible and safe and has the potential to reduce side effects caused by chemo, but they are not meant to establish practice guidelines for patients undergoing chemotherapy. And we really need quality controlled, randomized controlled clinical trials to determine the effect of fasting on clinical outcomes, including including quality of life and therapeutic index. This is just a schematic of how intermittent fasting works. I'll move past that in the interest of time. But another thing I wanted to focus on when thinking about diet is even if you don't adhere to any of these modalities, timing of when you take in sugar matters. Sequence and exercise also influence your glycemic index spike. So you can see here in this example, when a patient eats pasta, high carbohydrate first, and a vegetable second, that there's a high glycemic index spike. So the body sees a lot more sugar. But when broccoli or high fiber intake precedes the carbohydrate intake, the glucose spike is actually much less. So what the timing of when you eat carbohydrates is important. And I would suggest eating them after either a salad or high vegetable intake before. And you can see here with the example of M&Ms on an empty stomach, there's a high glycemic index spike. But when this particular person had dinner, a chicken salad, and then walked after taking the M&Ms, that the glycemic index spike was much lower. So something else to think about. I want to focus also on natural product use and supplements in oncology. I'm sure we always see everything promoted as a miracle cure online, and it's hard to discern what's real and what's spurious out there. But chemotherapy is actually naturally derived itself. So it's not far-fetched to think that some plants can be chemobiologically active and have effects in the body. The drug paclitaxel, which many of our patients with ovarian cancer will see at some point in their life, comes from the bark of the Pacific yew tree. Topotecan, another commonly used drug in this space, is derived from the happy tree. Vincristine comes from this beautiful flower of the Madagascar periwinkle, and trabectedin, more used in endometrial cancer, is derived from the sea squirt. So chemotherapy does grow on trees in some regard, but chemotherapy is not considered a botanical product because FDA, the way we describe botanicals, are that they have to be products exclusively containing ingredients from plants, algae, fungi, or combinations thereof. And botanicals really exclude derivatives, and chemotherapy is a derivative. It's a highly purified single molecular entity that comes from a naturally occurring source, but is by no means natural anymore, including paclitaxel and also genistein from soy. So what do we know about natural product use in patients with cancer? So the most commonly used complementary and alternative medicine modality in patients with cancer are herbal supplements, and 1 in 7 patients with cancer will use herbs after being diagnosed with cancer. There's a greater herb use in patients with cancer and other conditions, and over half of patients using these supplements do not report their use to doctors because they have a fear of being ridiculed or because they'll say that the doctor never asked. And we also found that there's a particularly high use of CAM in women with ovarian cancer undergoing chemotherapy. In the UK, 44% use to 52% use in Canada, and this was published in our review. So what's controversial about using supplements for cancer prevention? Well, we know from trials like the ATBC trial, looking at over 50,000 people who are high risk for developing lung cancer and very avid smokers, had an increased risk of lung cancer when taking beta carotene as a preventative supplement. In the SELECT trial, we found that men at increased risk of prostate cancer just taking vitamin E had a 17% increased risk of developing prostate cancer. And even taking folic acid is not preventative against colon cancer. And there was a higher association with colon polyps with patients using folate or folic acid, which are colon polyps are precursors to colon cancer itself. So this is a little bit concerning. What about supplements in during therapy? during cancer treatment. So this particular trial looked at 540 patients with head and neck squamous cell cancer who were undergoing radiation, and they randomized them to either receive vitamin E and beta carotene or a placebo. And the supplement arm, interestingly, had decreased adverse effects. So the patients taking supplements felt better, but had an increased local recurrence of disease and decreased overall survival of any cause. So taking supplements actually was associated with their cancer coming back sooner and having a decreased overall survival, which is very scary and alarming. And the theory might be that while our healthy cells are deriving benefit from these antioxidants, the antioxidants might also be protecting cancer against the reactive oxygen species and oxidative damage that we're trying to incur as treatment. So it could be reversing some of the damage to the cancer cells, maybe too. So we don't want to use supplements during cancer treatment. But we found in our pooled analysis of 10 cohort studies that there was no association between vitamins A, C, folate, and multivitamin use during adulthood and ovarian cancer risk. But the NCI cautions antioxidant use in this patient population. Another alarming study was the SWOG study, looking at supplement use during chemotherapy and survival outcomes of patients with breast cancer. And they found that use of any antioxidant supplement, including vitamins A, C, E, carotenoids, and coenzyme Q, both before and during treatment, were associated with an increased risk of cancer recurrence, and to a lesser extent, death. So in breast cancer, antioxidants may also increase recurrence, but not all supplements are bad. And in our review published in Cancer with cervical cancer, folate and vitamin B12 at high concentrations were found to independently protect against the development of more advanced premalignant lesions, cervical CIN1, CINS2, and CIN3. So cervical cancer, folate and vitamin B12 may be protective. What else should we think about when supplements are being used in the scheme of cancer treatment? There could be drug-herb interactions. So the herbs themselves may interact with how the body processes the chemotherapy. There could be a delayed clearance of the drug and accumulation of chemotherapy in the body, leading to increased toxicity. And certain herbs can also speed up metabolism, increasing metabolic activity and processing of the chemotherapy, leading to subtherapeutic exposures. And we know that certain herbs get processed by certain enzymes in the liver. And so it's important to talk to an integrative oncologist, or, at Dana-Farber, we have the ZACM Center where we have pharmacists looking at herb-drug interactions for patients with chemotherapy, cancer undergoing chemotherapy, taking supplements. So we give a certain survey to these patients, and then the pharmacist will look at the specific CYP enzymes to make sure that the herbs that the patients are taking do not interact with the chemotherapy. And if you're interested in learning more about this, I am partnering with our pharmacist at Dana-Farber Cancer Institute and the ZACM Center at our Society for Integrative Oncology annual meeting, which is going to take place this October, the 27th to 29th in Boston. And we're hosting a pre-conference workshop about how we analyze patients with cancer taking supplements. So we'd love to see you there. Moving on to talk about other supplements in GYN cancer, mistletoe has been very popular and is it's studied widely in Germany. There was a phase 1 trial by our colleagues at in Maryland at Johns Hopkins. Dr. Powler looked at this was a phase 1 trial to look at phase 1 intravenous mistletoe extract in advanced cancer, and she looked at 17 patients. Using IV mistletoe during treatment and as a treatment, and objective responses were not observed. So at best, IV mistletoe was the best response was stable disease that were observed in 5 patients. One of them had an ovarian cancer tumor, and the other ones had different types of tumors. So taking mistletoe doesn't prevent cancer, but with patients who took it, it didn't shrink the cancer, but one patient had stable disease. So more research is needed on that, but I think a more robust response was anticipated from that trial. The ASCO 2023 educational session also focused on the appropriate use of dietary supplements during and after cancer treatment, and cautioned that while vitamin D is good for bone health and immune support, it could induce the 3A4 enzyme. Multivitamins contain antioxidants. They could have estrogenic ingredients and absorption issues. Fish oil is touted for anti-inflammatory benefits and nutrient support, but also may increase bleeding risk, and so can turmeric. Melatonin is used for sleep support and immune support, but may have possible antioxidant effects and is processed through CYP1A2. And medicinal mushrooms are also being widely studied now for immune support. There's a question of whether they could have antioxidant effects, hepatotoxicity, and bleeding risk, and also get processed through the CYP system in the liver. And Gary Dang, interestingly, at Memorial Sloan Kettering, looked at maitake mushroom concentration in breast cancer patients and found a difference in whether the mushrooms were immunostimulatory, which is good, or immunosuppressive, which is bad in patients with cancer, and found that depending on the concentration in the blood, the effects differed. So even one supplement at different dose levels can have a different effect in the body, which is important to know. And another particular mushroom extract that I'm interested in studying is called AHCC. And there's been studies that have showed that AHCC supplementation boosts T cells and helps support immune function to clear persistent HPV infection. And this is also being studied now in ovarian cancer. Our colleagues at UC Davis are looking at AHCC in a clinical trial to improve quality of life for patients with ovarian cancer undergoing treatment. And this is actually a picture I took in the lab of AHCC. So they grow this mushroom in the beer vats that they use in Sapporo to incubate them and to help them grow. So I actually got a tour of the facility, which was fascinating. We can talk more about that during the Q&A session. But finally, I wanted to address patients coming to me talking about recycling the use of old drugs to treat ovarian cancer. There's clinical trials now looking at metformin, for example. A lot of patients are interested. I know our example patient, Mrs. A, was talking about Fenben or fenbendazole, which is in the same family as itraconazole. These are antifungal medications, and ivermectin is getting a lot of attention these days. And there's potential mechanistic abilities of these drugs to influence the cancer-resistant pathway. But again, we need randomized controlled clinical trials to show that these are safe and effective to use, and we just don't have strong enough data yet. So what can we talk about? What do we tell our patients and counsel them at this time? I recommend that patients stop taking antioxidants during chemotherapy, but if you're intent on taking them, definitely just hold off at least days 1 through 7 of chemotherapy the first week. Avoid high doses of beta carotene, selenium, or vitamin E based on the studies that we discussed before. And omega-3 and turmeric, you should be avoided when your platelets are low because these can increase risk of bleeding. A question that comes up a lot is soy okay? And in previous years, we thought that soy was bad because we know that it binds the estrogen receptor, and ovarian cancer is an estrogen receptor positive cancer. But as data accumulated and we started to understand processes more and metabolism more, the current thought is that the isoflavones or phytoestrogens, even though they bind the estrogen receptor, they downregulate it. So that soy is probably okay. It binds estrogen receptor but decreases the expression of it. So maybe it could even be protective. I wouldn't overdo the soy and take a lot of soy supplements, but I wouldn't necessarily go out of my way to avoid it. I think if you're just eating a tofu salad once in a while, that's fine, but don't make soy milk your supplement, your drink of the day like my other patient was doing. So we had her not take soy protein shakes every day. And finally, I want to address the microbiome and cancer. So 70% of our immune system lives in our gut. And our gut, and the gut microbiome significantly contributes to the makeup of our cells and DNA, dramatically influencing our physiology. We don't even make our own vitamin K in our body or clotting factor. It comes completely from production of microbiome in our gut. And the gut microbiome can enhance or protect us against the risk of cancer, can enhance the risk of cancer or be protective. And the gut and tumor microbiome also affects our response to immunotherapy. So here are some harmful pathogens that we know can enhance risk of cancer. And again, more than 16% of human cancers are currently felt to be related to microbiome, including gastric carcinoma that's caused by H. pylori, C. jejuni can cause a lymphoma in the small intestine, Salmonella typhimurium can cause hepatobiliary hepatobiliary carcinoma. MTB can cause lung cancer. Porphyromas gingivalis can cause pancreatic cancer. And we know there's a very strong correlation with HPV and cervical cancer. Now, there's a microbiome that's specific to the cervical vaginal area that's different from the gut microbiome. And this is called the CVM, the cervical vaginal microbiome. And from our understanding now that there are 5 community state types in the CVM. 4 of them are good and have a high prevalence of lactobacillus. And one of them, CST, community state type 4, is the bad one. And that one is devoid of lactobacillus and has the highest microbial diversity. And this is the state type that's associated with yeast infections, STDs, vaginosis, UTI, pelvic inflammatory disease, and possibly even cervical cancer. Now, what about the CVM and ovarian cancer? One particular study that was recently conducted by Nene et al. In 2019, just a few years ago, found so this group divided the 4 good types and called into one. They combined all the 4 good types into one community state type and called it community type L, and then they called the bad type community type O. So if there was greater than 50% of species of lactobacillus, you had the good type, and if you had less than 50% of lactobacillus, then you had the bad type, community type O. And they found first that women below the age of 50 and women above the age of 50 had different prevalence of microbiome in the CVM, so different community state types in the CVM, but just based on age. And then looking specifically in women less than 50 years old, there was an association with having the adverse type, the community type O, in women with a BRCA1 mutation and also in women with ovarian cancer. Again, this is pretty new, and we're just starting to scratch the surface as far as our understanding of the CVM and ovarian cancer risk, but I wanted to share this data with you. Jennifer Wargo and the group in Texas has studied the microbiome in the gut in response to immunotherapy, and have found that among responders and non-responders, there was there was different concentrations of the microbiome in the responders versus non-responders. Responders had a higher concentration of Clostridia, and non-responders had a higher microbiome makeup of Bacteroides. So this was really interesting and can influence our understanding and treatment of cancer. Can we change the microbiome to influence our response to different therapies and prevent our risk? Patients with depleted gut flora may respond more poorly to immunotherapy. So again, modulating the microbiome may help improve cancer therapy responses. Immunotherapy has a role now in metastatic cervical cancer and endometrial cancer, but not a lot of headlines for ovarian cancer yet. But there are some regimens that do combine pembrolizumab with some standard of care chemotherapy in standard of care treatment at this time. And here's a really nice schematic that shows how alterations in the gut microbiome can impact the development of gynecologic cancers via changes in pathogen translocations, metabolite release, and modulation of even estrogen levels, hormone levels in the body. So in summary, there's an increasing role for the microbiome in health and disease, and the strong evidence that the gut microbiome may influence host and anti-tumor responses as well as response to checkpoint blockade or immunotherapy. But we need more trials to see if we can modulate the microbiome in the gut and in the cervical vaginal microbiome to enhance response to immunotherapy and other treatments. There's more questions than the answers at this time. Should we profile microbiome of patients going onto therapy? What's the role of antibiotic use in these patients? Should we consider a probiotic diet or different dietary intakes? And what's the role of microbiome in preclinical models? So we still have a lot to learn. We know that physical activity is important for lifestyle modification. As far as herbs and supplement goes, for patient A, we don't want to recommend antioxidants. Vitamin B12, folate, and vitamin D may be okay. We understand now more of the effects of sugar with ketogenic diet and fasting. We know that it's safe and more efficacy studies are needed, and we're just scratching the surface as far as cervical vaginal microbiome and the risk of ovarian cancer. So in conclusion, our patients are using nutrition, dietary supplements, probiotic, and lifestyle changes to prevent and treat cancer and improve quality of life while undergoing cancer treatment. And we've really come a long way in understanding the importance of food and drug safety, but more research is really needed to see how these interventions affect cancer. And again, I've said this several times, but really honing in that rigorous clinical trials will enable practitioners like me to advise what's safe and effective. Oh, let food be thy medicine, and medicine be thy food, in the words of Hippocrates. And if your diet looks like this, not this, you're doing it wrong. We should be focusing on getting our nutrients more from organic foods and a diverse diet than really focusing on taking supplements because there's not a lot of regulation and we can't ensure that what you're taking in the pill is what is listed on the label. And if you are interested in learning more, I wanted to include some reliable supplement resources for you here. And just to focus last on our Zakim Center for Integrative Therapies and Healthy Living. For patients who have been seen at Dana-Farber, you're eligible to visit the Zakim Center. You can get an integrative medicine consult with one of our pharmacists or MDs or PAs. We offer acupuncture, massage, exercise, nutrition counseling, meditation and mindfulness classes, yoga and acupuncture. And this is really exciting as well. Some of our colleagues are enrolling on clinical trials now for quality of life, looking at acupuncture, yoga, telehealth intervention to reduce fatigue, strengthening, exercise in patients with advanced gynecologic malignancies, exercise as a preventive agent to combat immobility in patients with ovarian cancer, endometrial cancer, comprehensive outcomes after cancer health, and promoting gynecologic patients with frailty to achieve functional recovery. So a lot of integrative interventions that we're working on now at Dana-Farber. Again, I'd like to invite you all to come to our Integrative Oncology Conference that Harvard Medical School will be hosting this year. And I wanted to leave a couple of minutes for questions at the end. I know you guys have a lot. So thank you for listening, and we'll be focusing, I'll move over to the chat now. Okay. Let's see, everyone. All right. Okay, I'm just going to start from the bottom because that's what I'm seeing first. How do you get your CVM tested? So right now, we are testing the cervical vaginal microbiome as part of a biobanking clinical trial initiative. There are companies out there that are, I believe, offering this to the public, but I think Viome is one of them, Viome, but I'm really not endorsing any of them. I haven't had personal experience with them. Right now, we're looking at more from a clinical trial standpoint where we are doing the collections ourselves, but there are some companies out there that are offering this. I can't attest to the reliability of those, and I don't recommend them at this time. Recommend not eating sugar. How much per day is tolerated? So it's impossible really to not eat sugar because everything essentially that we eat gets broken down into sugar. I think it's important to modify or limit processed sugars and processed foods in general. I think if you're focusing on lean meats like salmon and chicken, and getting a high intake of fiber from vegetables, either cooked or raw, and eating those first. And then if you have a sweet tooth, even showing, the glycemic index spikes, having something sweet after a meal can help. There's really no gram limit that I would say is tolerated. Can you repeat the date and time for the integrative conference? Sure. So our workshop is going to be the pre-conference workshop before the conference, but the dates are the October 27th to 29th. So our workshop is going to 27th. Beyond a healthy diet, do you suggest supplements that are helpful? You are currently NED to prevent recurrence. So nothing officially yet, but there are preliminary studies that show supplements like AHCC might help stimulate the immune system, T cells. But again, nothing ready for prime time that I could officially recommend, but just there's a lot of exciting mushroom supplements that I'm looking into now. Do you feel artificial sweeteners play a role in ovarian cancer? I can't say that they do, but actually, I think last week, a study just came out that showed artificial sweeteners were associated, and this I think is in the Academy of Neurology, just published this study that higher use of artificial sweeteners was associated with, I think, dementia, and there was some negative and adverse association there. So I don't think they're good in general. Um, so if I would avoid them if you can. Um, what's a therapeutic dose of AHCC? I have high-grade serous ovarian cancer, but I'm also P16 positive, which I believe AHCC can help, right? I wouldn't recommend these supplements without being on a clinical trial because we don't have data, official data that shows they're safe and effective, but based on Judith Smith's randomized placebo-controlled trial, they used 1,500 milligrams twice a day. So it seems based on that study that 3 grams a day was well tolerated, and the only adverse effect was GI toxicity. But again, talk to your doctor, make sure that any supplement you take doesn't interact with any other medications you're taking, including cancer treatment. Um, how do steroids impact blood sugar? Before I started chemotherapy 8 years ago, my blood sugar was normal. After steroid use, which is giving me stop nausea and vomiting, my blood sugar is higher. Yeah, steroids, it's double-edged sword. They treat, and this is a problem that we see with most drugs. They do one thing and then cause another problem. And then I always think of the book, If You Give a Mouse a Cookie, that then you have to have a glass of milk. So then you need something to lower the sugar, maybe metformin. So, it's complex. And if steroids are what's helping you for nausea, but that they're really good for them, there's a high efficacy, but um it can cause increased blood sugar. Someone else hates them and they're making her starving and not sleep. Yes, those are common side effects as well. Anyone looking at Mounjaro or GLP-1 shots for weight loss and whether safe for ovarian cancer patients are survivors. As far as the Mounjaro GLP-1s reducing obesity, I think that just based on that association, that there'll be a protective effect. But now I think, at least in the preclinical studies, there could be an increased association with thyroid cancer, maybe. Don't quote me on this, but I think there's also side effects and toxicity from the GLP-1. Like I said, the give a mouse a cookie analogy, that you're treating one thing, but it could cause other problems. So I would talk to your oncologist and your primary care doctor about that first, and also maybe have an endocrine consult, whether it's safe for you at this time. But I think as far as reducing obesity, we know that lowering your overweight status, or lowering BMI can be protective. So just in that regard, yes. How about honey intake? Better than sugar. I think that's a better alternative. Honey is also naturally antimicrobial, has other good effects. I would recommend that. And I think you can look up. I can do this, but I have so many windows open, but there you can Google or chat GPT, the glycemic index. So honey versus a maple syrup have different glycemic index than sugar. And I think you can even use pulverized dates as a form of sugar if you're going to bake, versus pure cane sugar itself, which is a natural alternative. If your ovarian cancer is folate receptor alpha positive, should I avoid B12 or folic acid or folate supplements? No, this is it's folate receptor alpha is different. You don't need to avoid those supplements, but as far as Ella here goes, and there's a lot of clinical trials and exciting data. So I think it's having folate receptor alpha positive status is good for eligibility for current drugs that are on the market. Do you have any suggested proven natural therapies that can help with treatment-induced menopause symptoms? This one we see a lot. I work in the cancer prevention clinic, and a lot of patients get prophylactic oophorectomies and salpingo-oophorectomies. Um, there was a bee pollen extract that doesn't have a lot of data on it, but that anecdotally was being used, and the name is escaping me, but it could possibly help. I might have to email that at the end if it doesn't come to me. But there was a study that showed that acupuncture could help, was just as effective as venlafaxine, which is an SNRI, an antidepressant, when being used for hot flashes and some of the menopausal symptoms. So I would look into acupuncture if it's safe and if your blood counts are high enough. What is your contact email? I could share that at the end, or I'll have them give that out. What about juicing? Beet, celery, apple, scale, or smoothies better than juices? Um, I think juicing is fine. Just a word of caution, if you have a high concentration of fruits, I would juice more um, vegetables than fruits because fruits are high in natural sugar, and you wouldn't eat like five apples or an apple, banana, and orange and grapes and all this fruit that you might put together a smoothie in one setting because you would get full. You lose some of the fiber with juicing. So I think a smoothie, yeah, I think smoothies will be better because it will fill you faster and you might consume less. But just be cautious that you're going to increase your caloric intake when you combine a whole bunch of food products in a smoothie, but I think vegetables are better than fruits in that regard, less sugar content. Um, oh my goodness, we're getting so many questions. Monk fruit extract, um, better than honey or maple syrup. You can Google, we can look up the glycemic index of these things and you can see like which one is the lowest. I'm not sure off the top of my head, but I think monk fruit, extract should be fine. Again, they all turn into sugar at the end of the day. What about probiotics? Probiotics are generally safe. I like to recommend that patients interested in probiotics consume more probiotic friendly foods like yogurt or kimchi or fermented foods, and to get probiotics in naturally. Again, I'm weary of what goes into supplements and how much you're getting from a product on the shelf. If it's, there's no guarantee what transitions from the pill to your body. Um, Tracy has shared that there were several questions asking about the value of Mediterranean diet and is it equal to ketogenic diet? I think the Mediterranean diet is great. I think it's high in healthy fats, but then the Dr. Miriam Al-Hilly's mouse study did show that the ketogenic diet in the mice that made the tumors grow faster. So it's really difficult as an oncologist to prescribe a diet and say that this is the best diet for everyone. I think avoiding sugars and low carbohydrates and getting a lot of natural food products, which is what the Mediterranean diet inherently has, is a sound strategy. But it's challenging to be in this position, and I don't want to recommend something that doesn't have strong data. Um, what about the DASH diet? Again, all these different diets, we really need randomized controlled placebo, randomized clinic controlled trials to show that patients with a type of cancer, with ovarian cancer, following one diet does better than another. We don't have that data. I think just again, as a rule of thumb, just moderate, minimizing processed foods, the junk foods, what the AICR and the WCRF were explaining, just intuitively not having the high red meat intake, avoiding fast food, avoiding sweetened drinks, and just, eating natural foods from the earth. Um, FODMAPs diet for IBS diarrhea. I think if FODMAPs works for a particular body type, then that's great. Red meat or plant-based whole foods. Red meat is pro-inflammatory, but if you're anemic and you have low nutrient levels, that's also a great way to get an iron. I think if your iron is adequate and it's minimizing red meat has been shown to be protective. So I would minimize red meat. Is metformin safe for endometrial ovarian cancer? There are studies looking at metformin in combination with other drugs. So it's I don't want to say yes or no, but there are clinical trials and the data will be coming out about metformin in ovarian cancer. Um, okay, we have a few more minutes. Um, Juice veggies instead of fruit. Yes, someone liked that recommendation. Mike, Relazin, thank you. Thank you, Melissa. Yes, Relazin was the hot flashes. Supplement that I know some gynocs are recommending. There's not strong data on it again, so I'm not confident that it's either safe or effective, but I do know that it is out there being promoted for that use for what it's worth. So we'll have to do our research and see what else comes out about that. Does ways of cooking food influence the interaction of food and ovarian cancer? I think about this a lot, especially because my mother, who's a nurse practitioner, goes to Ojai and she does raw vegan diet for a couple of days and comes back and detoxes and feels really great. And then I have colleagues who follow an Ayurvedic diet. An Ayurvedic diet says that you have to cook products to activate them to get the nutrients and the enzymes out of them. So there's different schools of thought. So some people feel that a raw diet's better and you get all the enzymes naturally. I know for the benefit of lycopene, let's say from tomatoes, there's a benefit that a cooked tomato for lycopene concentration is better than a raw tomato. So there's the data is so conflicting, and the more I learn and the more I know, the more humble I become because I realize that there's so much more that we really need to understand about diet. So, um, it's really challenging to recommend one versus the other. So I hear good things about, I'll hear a talk about raw diet and I'll be convinced that I'll hear a talk about Ayurvedic diet and how, you really need to cook the food to activate it and process it better. So, every time it becomes overwhelming. How do we make our microbiome not conducive to cancer? This is a very important question that hopefully we will be able to answer. I don't think we can answer it today. The way that, Dr. Wargo's doing it with stool transplants and, the clinical trials, it's again, nothing ready for prime time yet, but we're just scratching the surface in terms of understanding good bacteria, bad bacteria. Lactose is not recommended. What about yogurt? Yogurt, I would say the Faye, the Greek yogurt, I think has the lowest sugar in it. And try to avoid yogurt that has quote unquote natural flavors because you want natural flavor actually isn't natural. You want if it's flavored with something to have that, if it's a fruit extract, to have that fruit extract in it. Um, Thank you for this new info. Thank you for coming and for listening. No antioxidants. I feel like I missed something really important here. We should not be naturally consuming them during treatment. Please clarify that one. So during days 1 through 7 of chemotherapy, that's when you want the chemotherapy. The chemotherapy, unfortunately, works by causing oxidative damage, which works on the cancer cells and also causes damage to our good cells, which is why the patients on the head and neck clinical trial who took antioxidants felt better but had increased recurrence of disease. So I think it's okay if you're getting it from your diet because again, it's the foods with antioxidants are generally healthier, but there's really no way that we understand today that can ensure that the antioxidants only go to your good cells and not the cancer cells. Um, I would just be mindful of supplement intake, but as far as, worrying about fruits with antioxidants, if you wanted to, minimize during the first week of chemotherapy, it's something to think about. It's not an official recommendation that I would make at this time. There's a lot of other um, elements and minerals in a whole food, so I think taken as a whole food, it's okay. But just I would avoid supplements during um, the first week of chemotherapy. Um, Oh, someone wanted to know why the Mediterranean diet wasn't mentioned today. I only have a limited amount of time. But thank you for bringing it up. Maybe I'll add Mediterranean diet on a future slide, but I'm glad we got to talk about it during the Q&A session. Also, the Mediterranean diet is less extreme than some of the other ones, so I felt that, ketogenic diet and really focusing on the role of sugar based on the concerns of Mrs. A, to inform the flow of the talk. Sauerkraut, I think is good. Caviar and yogurt, it's whole milk from Brenda. Yes. Um, is it okay to take prebiotic or probiotic during treatment? I was told no. And the fear is that when you're undergoing treatment, you can become neutropenic. So your white cell counts can become low and you're depleting a lot of the bacteria and so in your body. So you don't necessarily want to be supplementing other bacteria because who knows if you could get infected by it. I think there was only one case anecdotally of a patient who was taking from my infectious disease colleague who told me this, that they saw one case of like a lactobacillus sepsis of a patient who really overdid it on the probiotics when they were neutropenic. But in general, I don't think that's common, but I think it's safer to avoid, supplements during treatment and just to get probiotics again naturally through sauerkraut, kefir, kombucha tea, um, are higher levels are higher doses or lower doses of mushrooms recommended? Um, Again, I'm not making any of these recommendations, but based on the study from Gary Dang, he found that the lower concentration of the mushroom was immunosuppressive and the higher concentration was immunostimulatory. And that's all I'll say about that. Um, any replacements for melatonin for sleep, looking at a trial that will require me to discontinue melatonin. Sleep has been a major issue, and we are actually working in the Society of Integrative Oncology with ASCO to formulate some fatigue and sleep guidelines. So stay tuned. I don't have anything as far as a replacement for sleep yet, but there is preliminary data, and there will be more to come on that. Um, Someone else, I thought you couldn't eat enough soy in one day for it to actually affect your estrogen levels. In high doses, anything you eat over time can accumulate. But again, if you're getting it naturally from a tofu salad, I think it's fine. Just I wouldn't supplement or really overdo it on, um, for example, adding soy to everything you drink. How does what count sugars total? No doc has ever told me to stop sugar. How come? You can't really stop sugar. I think avoiding processed sugars and what we would consider junk food is always a smart idea. Um, to count sugars, you'd have to do a glycemic index and work with a nutritionist. I thought menbendazole was better for ovarian than benbendazole. Again, patients are really excited about the bendazoles and the ivermectin data. We, as oncologists, are a little bit baffled. We're not seeing this data and understanding where this enthusiasm is coming from. So we're not recommending it at this time. I'd love to see some strong clinical trial data showing the safety and efficacy of these drugs in combination with chemotherapy and in the cancer prevention space. I think there's a disproportionate enthusiasm from the public at this time for these two particular interventions, but more to come.
Dr. Berman,
Yes, we
I
were at time.
thank you so much.
Hard to get through
This
all of
is
that.
incredibly helpful, informative. The research has been really critical to validate, you know, and to help people understand where, some of these findings are coming from. We may have to invite you back if you'd be willing at some point because you can
Love to
see
come back.
there's an overwhelming interest in this topic, and I can't thank you enough for how clearly you explained it all.
Thank you so much. Thanks for having me. And thanks for everyone's interest in such an important topic. And I think, hopefully in a couple of months or the next time, if I am invited back, we'll have more data and more exciting research to share. So definitely more to come in this space.
And thank you for sharing the conference in October. We'll check it
Thank
out.
you. Okay, great. Bye, everyone.